We're moving on here. We have from New York, Sloan Kettering, Dr. Carvajal, and I'm going to turn it over to him.
Thanks so much, guys. I'd like to thank Grant for putting this all together, Takami and the folks from Jefferson for hosting, and for all of you guys coming out. I think this is really, I love coming to these forums because I think very strongly that uveal melanoma is such a complex disease, more so than even a lot of other cancers, and this is a disease where so many of us have to work together. It's not just medical oncology, not just ophthalmology, but radiation oncology, the scientists, and the patients. And so the more that we can all be in the same place together, I think that's, the better. So let me see if I can figure out how to get my slides on. But what I want to focus on is really kind of what we're doing to develop treatments for patients if the cancer comes back, if the eye surgery or the radiation itself is not curative. And this is a challenging kind of topic, as you know, because historically, before this year, we have not had a drug, a systemic therapy that's been effective. So what I want to do is kind of, sometimes I see a lot of patients, unfortunately, with advanced disease in my clinic. And so I'm basically going to go through the things that I end up talking through in clinic. Some of you guys have met me, so it might be old hat for you guys. And we can keep this informal also. If you guys have questions and you just don't want to wait till the end, that's okay as well. Okay, so this is just background that you guys are all very well aware of. But uveal melanoma, this is a disease that arises from pigment cells of the body, just like skin melanoma. But I always make a point of saying that although it arises from the same cell that a skin melanoma does, it's completely different. It's biologically different. It behaves differently. It responds to treatment differently. And so we have to, when we try to develop treatments for this, we have to think of it as a completely unique disease. And again, until 2013, there really was no effective systemic therapy for patients with advanced disease. And so historically, and even today, I feel that the standard of care for patients with metastatic disease is a clinical trial. Now, what I show here is really, this is it in terms of FDA-approved drugs for melanoma. And these approvals were made for skin melanoma, not for ocular melanoma. Okay, I'm not going to go through all of these, but I do want to kind of point out one, which is ipilimumab, which I think some of you guys have probably received or at least heard about. This is Yervoy. And I'll mention a little bit about trametinib. But these other agents here, for the most part, do not have a role in the treatment of patients with advanced uveal melanoma. Ipilimumab, I got some questions beforehand from some of you guys, and people wanted to know about mechanism and stuff. So this is a mechanism slide. It's a little bit complicated, but I'll walk you through it. This kind of tries to explain how Yervoy or ipilimumab works. And this is an immunotherapy that basically functions by augmenting the effects of your immune system to attack the tumor. And to do this, you have to to understand how this works, you have to understand how T cells, which are the effector cells of the immune system, the good cells, how they get activated. And normal activation requires kind of two signals, which occur between what we call an antigen-presenting cell, and this is your T cell. So this is the immune cell here, and this is a cell that shows a piece of tumor or a piece of bacteria or something to the immune cell. And so the first signal occurs when a piece of, in this case, the uveal melanoma is presented to the immune cell. And that's kind of like signal one. And to use a car analogy, that's like kind of putting the keys in your car ignition. It kind of gets things primed. But for full activation, you need a second signal, which occurs when this thing called B7 on the antigen-presenting cell binds to this thing called CD28 on the immune cell. And when that happens, you get full activation. The T cell gets turned on. It can attack a tumor. It's like putting your foot on the gas pedal. But when that happens, your body has this kind of negative kind of feedback mechanism so that your immune system doesn't go overboard. And that's mediated through this thing called CTLA4, or cytotoxic T lymphocyte antigen 4. So when the T cell is activated, this thing migrates to here, to what we call the immunologic synapse. And when it gets there, it binds to this thing called B7, but it binds to it tighter than does CD28. And when this thing happens, it shuts off the T cell. It's like putting the brakes on the immune system, okay? So Yervoy, what Yervoy is, or ipilimumab, it's an antibody that binds to CTLA4. It blocks this interaction here, so it doesn't let the T cell get shut off, and it allows the T cell to continue fighting the cancer. And this drug was actually the first drug to ever show that it helps people with skin melanoma once it spread live longer. So this was a huge, huge deal. And so the obvious question for us then is, does this work in ocular melanoma? And I think the jury is still out a bit. There have been 3 series now that have been published kind of asking that question, does this drug work in eye melanoma? And this was our series, which we did in collaboration with some of the folks up in Boston and with a group in Switzerland, where we looked at 39 patients who were treated with ocular melanoma. And I don't really want to go too much into the details, but I think the bottom line is it can help some people. The percentages may be the same as with skin melanoma in terms of shrinkage or with disease control. To be honest, this series, it seems that it didn't work quite as well as in skin melanoma, but I think this was not kind of a very strong clinical trial. This was a retrospective review that was not really designed to answer that question. So I think my take home from this is that it can help some people. Does not help most, but it can help some people. We can still probably cure some people with advanced disease with this drug, but we can't pick who those people are. There was a larger series that was published shortly after ours by the European group that looked at 82 patients. They found very, very similar results that could help some people. And if you look at the response rate, the number of patients who get major shrinkage, it's low. We're still in the single-digit percentage range. But again, we had disease control. That is, we can stop the cancer from growing for at least a period of time in a higher proportion of patients. Okay? So of the FDA-approved drugs for skin melanoma, Yervoy, I think, is reasonable to think about. And there are well-designed prospective trials that will answer the question of does this really help or not in eye melanoma. Okay? I think what's available, it suggests that it can, but we don't know the true percentages. Okay? A lot of the advances we've made in skin melanoma have been based on our understanding that even in skin melanoma, it's not all one disease, but it's rather a collection of heterogeneous molecular subsets of disease. And so, what we've done is we've taken the entire pie of, let's say, skin melanoma or all melanoma, and just broken it up into different genetic subsets. And some of you guys might have heard about BRAF mutations in skin melanoma. And that's a big deal because we know that about 45% of patients with skin melanoma will have tumor with a BRAF mutation. And that BRAF mutation is something that drives the tumor to grow and spread. And if we shut off BRAF in those tumors, we can get major anti-tumor effects. We can shrink cancer in almost all patients we treat. We can improve survival. We can do all the things that we want to do. But this leaves another 55% of people in the pie. And so we know a bit of what's in the rest of that pie. We know that about 20, maybe even more, percent of patients with melanoma in general will have tumor with a mutation in NRAS. It's just another protein in the tumor that leads to tumor growth. And we're working to try to develop treatments for NRAS mutant melanoma. We know a small proportion of patients will have tumor with a KIT mutation, and we have treatments that we can use for those. In a significant proportion of the pie, we say that they're wild type, which means they don't have a mutation in BRAF, NRAS, or KIT, or GNAQ or GNA11. And for those patients, we're still trying to find out what are the key drivers, what's making that cancer grow. And once we figure that out, then we can try to develop treatments that make sense. And then what's pertinent for eye melanoma is that we know that the majority of eye melanomas will harbor mutations in GNAQ and GNA11. And so I'll talk a little bit about that just to try to answer that pathway question. What is GNAQ, or what is GNA11? Well, these are genes that encode for a protein that is part of what we call a G protein. All right, and a G protein is this protein made up of this G alpha thing and this G beta gamma thing, and this functions to couple signaling. This is a cell. So this is the cell membrane there. This is a receptor, which is like an antenna on the cell. And what happens is something in the bloodstream can land on that antenna, activate the receptor, and then tell the cell to do something. Okay? Now these G-alpha mutations lead to a change in this part of this pathway, which makes it always active. So normally, the signaling should be turned on and turned off depending on what the cell needs. In this case, in eye melanoma, that signal is always on, and it's always telling the cell to grow. Okay? So, for instance, for skin melanoma, where there's a mutation, this thing called BRAF, which is in this part of this kind of complex pathway, if we inhibit BRAF in skin melanoma, we can get major tumor responses. And so that begs the question of, well, if this is the problem, if this is the mutated part of the pathway, why don't we just shut that down? And there are efforts to do that, but it's very hard to develop a drug to actually, that can actually do that. And people are working on it, but we're years away before actually finding something that can do that. And so what we've done otherwise is to try to not target G-alpha, which is the mutated thing, but inhibit or target machinery in the cell that are turned on downstream of that. And that led us and others to look at, what if we inhibit that G-alpha pathway at the level of MEK? And we asked that question because we had drugs that did that. So it doesn't shut off G-alpha, but it shuts off the pathway, one of the pathways that G-alpha activates. Okay, sorry, this is complicated, I think. You guys still okay? I know it's right after lunch, too, so everyone's sleepy. So I think everyone's still awake. So in the lab, what we did was we took a bunch of uveal melanoma cell lines and then treated it with MEK inhibitors. And what we showed is that particularly in the cells with those mutations, the GNAQ and GNA alpha mutations, we could actually kill those cells. And we looked back historically at another clinical trial that was mostly done in patients with skin melanoma, but some of those patients actually did have uveal melanoma. And it seemed that those patients treated with this drug called selumetinib, which is a pill that blocks MEK, it seems like they did better than the patients who got chemotherapy. And so to kind of more formally assess, does this actually make sense, we developed this clinical trial in collaboration with the National Cancer Institute to try to figure out, does MEK inhibition with selumetinib work? And so I'm going to tell you a little bit about this trial, because this is work that we presented in Chicago in June, so this is fairly recent. But on this study, we took patients with ocular melanoma that had spread, that we could not cure with surgery or whatever, and patients cannot have had received prior chemotherapy with something called temozolomide or dacarbazine, which are just some old chemotherapies. And we randomized them to receive either the experimental pill, which is the MEK inhibitor, that's the selumetinib, or chemotherapy with temozolomide. And we treated them. And if patients who got the chemotherapy, if their cancer grew, then they could receive the selumetinib after. Okay, this study design, I think, probably raises a lot of questions because I've talked to a lot of people about this. People don't like the idea of randomization. Obviously, everyone says that, if you think selumetinib is a drug that's going to work, why are you going to give someone chemotherapy if you don't think chemotherapy is going to do well? And that's a very, very good question. The answer is, I guess, twofold. One is, when we're doing these studies, when we're trying to find a drug that works, we have to figure out as a group what is the primary endpoint. What is important for us to figure out? Ideally, we all want a drug that will cure you of the disease, but at the very least, we want a drug that's going to help you live longer without side effects, so you feel good, you can do the things you want to do. And to design a trial like that where we're looking for a survival difference, that takes a lot of time, and that's a very expensive trial. But another way that we can try to look at efficacy is to see how long can we control the cancer for before it starts to grow. And that's looking at, kind of a disease control rate. But to design a trial to look at either survival or disease control in a clinical trial that the FDA will consider for registration to get it approved, it has to be randomized against some control. Because we cannot do a study of a drug, and let's say patients live for 20 years, okay? Is that good or bad? We don't know without a control, because we don't know what they would have got, how they would have done without a randomization. So that's the problem, that's our struggle, okay? We want to get you guys, all of us want to get drugs to you that work as fast as possible, but we have to do it in a way that will potentially get it approved so it is accessible. And so this was done to try to, in that effort. I think the second question that people might ask is why use chemotherapy, and that's a very good question. We've discussed this over and over again. I guess the question I would ask back is what would we use as the control? In a disease for which there is nothing that works, we could argue that we could just do placebo. which might be theoretically the right answer, but obviously I would be uncomfortable giving someone placebo, and I think as patients you would be uncomfortable taking placebo as well. Chemotherapy can work, it's anecdotal. The response rate's low, we know that, but it can be effective, and this drug is well tolerated with very few side effects, and we thought this was a reasonable compromise, but obviously something up for discussion, something I discussed with many, many people before we started this trial, so not an easy discussion. But anyway, so this was a study design. I spent a lot of time on that, sorry. Big trial, we actually put on more than 120 patients on this trial, and to do that, obviously we couldn't do this ourselves at Memorial, so we recruited, I think 14 or 15 other centers, including Jefferson, to help us with this. The point of this slide is that I feel very strongly that this is a team effort to try to find treatments for this. This is not a Memorial Sloan Kettering thing. This is not a Thomas Jefferson thing. This is kind of a field-wise. We work very closely together, okay? And I want you guys to know that we all know each other. We all work very closely together, and there is a lot of interest in actually trying to cure this disease. So anyway, so as part of the trial, at baseline, we looked at mutation status for GNAQ and GNA11, and as expected, the majority of the patients we treated did have a mutation. What I do want to point out is that about 16% of patients did not have one, but the mutations that we were looking for were the more common mutations in part of the gene called exon 5. After we started the trial, there was another mutation in another part of that gene in exon 4, and we did find that another, probably half of the patients who did not have an exon 5 mutation had an exon 4 mutation. So really, I think over 95% of patients will have a mutation in either GNAQ or GNA11. And we can talk more about that if there are questions. And that's consistent with what we've seen historically. Okay, so this is the response data that we've seen on our trial. And this is what's called a waterfall plot. On these waterfall plots, basically each bar on the graph is a patient, and they're color-coded by mutation status. And if the tumor grows on treatment, the bar goes up. And so this patient right here, who was treated with chemotherapy, at the best it grew by like 60%, okay? But if the bar goes down, that means it shrunk. And what you'll see here is very few patients had tumor shrinkage with chemotherapy, and no patient had major shrinkage consisting of what we would consider a major response for the purposes of the clinical trial. Whereas if you look, the graph is different for the selumetinib, where about half of the patients we treated did have some measure of shrinkage, and we did see major shrinkage in 15% of the patients. Okay, so biologically, we know that there's a difference here. The primary endpoint for our trial was progression-free survival. That is, how long can we control the cancer for? And what you see here is with selumetinib in red, progression-free survival was longer than with chemotherapy. The hazard ratio was 0.46, which means that we decreased the risk of the cancer progressing by 54% with selumetinib, okay? That's good. What you will see, though, is what is the actual magnitude of the control, and this is important for you guys, that with chemotherapy, we controlled cancer for 7 weeks on average. It's not good, right? With selumetinib, it increased to 16 weeks, so it more than doubles it, but certainly we still have a ways to go, okay? Now, almost all the patients, even if they got the chemotherapy first, most of the patients got the MEK inhibitor afterwards, and so that I think possibly muddles the survival difference. But in our study, people lived the same regardless of the randomization. But what we do see here is a higher response rate, greater likelihood to shrink tumor, and it's a higher response rate than we've seen for any systemic therapy before for this disease. And again, we doubled progression-free survival, okay? Overall survival, we didn't see a difference, but there was a crossover, so that's a muddled analysis. And something that's really important for us as we develop drugs is we did look at tumor biopsies before treatment and after, and that's very, very important for us because that's the only way we can tell if we're doing to the tumor what we expect to be doing. And this is something called a Western blot. And basically, remember, what we're trying to do with this drug is block a protein called MEK and shut that pathway down. And we shut that, and the way we can tell if that pathway is shut down is by decreasing this thing called phospho-ERK. And so for this one patient here, you can see at baseline, he's got a lot of this phospho-ERK protein, but after treatment, 2 weeks after, it's virtually gone. And it's the same thing with this patient and this patient. And all three of these patients did really well, with two patients who had major shrinkage, and this patient had disease control for 7 months. Whereas this patient here, before and after, it's kind of the same, which suggests that maybe the drug for some reason did not do what it was supposed to do there. And these patients, the cancer grew. And so if we aggregate the patients that we kind of looked at here, so we looked at 18 patients with these biopsies, you can see that for the patients who did well, the median suppression, the median decrease in that protein was 80% versus 26% in those who did not. And so it might suggest that to really get this drug to work well, we need very high suppression of that pathway. And I don't know if it's 80% or 90% or 95% or 100%, but possibly more is better. And that's what this suggests. And so this, as we develop, as we try to build on these results and develop newer, better trials, we have to keep that in mind. One of the drugs I showed that was FDA approved for skin melanoma is this drug called trametinib. And I bring this up because trametinib is another pill that blocks MEK. Okay, so it works similarly to selumetinib, the drug that we studied. And it was approved just in May, but it was approved for patients with BRAF mutant melanoma, which we don't find in eye melanoma. And so, I guess the question for us now is, one, can MEK inhibition, given our results, be considered a standard option? And then two, should we be using trametinib, which is this commercially available drug in this setting? And my answer is I don't know. I think it's reasonable to think about doing. We have very little experience of trametinib in eye melanoma, and it's kind of summarized here. I don't know that we need to go through it. We had some patients with some disease control, some with a little bit of shrinkage. I would like to point out that these two drugs are very different. Even though they both block MEK, they block it in a little bit of a different way. And so just because it works, just because one drug works, the other one may not. And so for that reason, I think that without regulatory approval of selumetinib, I still favor clinical trial participation. That being said, if you are in a place where you do not have access to some of these new drugs, and we need to do a treatment, personally, I think a trial of Yervoy is reasonable. I think a trial of trametinib is reasonable. There may or may not be issues with insurance about getting that drug, but I think it's something that you guys should keep in mind. How am I doing time-wise? I know I was going to talk too long. Okay, so the next question for us, maybe I'll skip through some of this, is how can we build upon these results? Because I do think that MEK inhibition does have activity. But we know that MEK is not the only answer. And it may be that we have to block other parts of this cancer biology, the mechanism, to get optimal results. And we do know that, at least in our data, that in patients with those GQG alpha mutations, you activate not just this pathway here, but you also activate this pathway called the PI3 kinase AKT pathway. And in our hands, if we block MEK concurrently with some of these other things like PI3 kinase or AKT, we kill the cancer cells much better than just blocking MEK alone. Also in the lab, if we block MEK concurrently with this thing called PKC, we get better results. And so based on that data, we have kind of a series of next generation MEK-based trials. And these are trials, all three of which I'm very, very excited about, and I think we can build upon what we saw with that first trial. The first one here is a trial that's sponsored by AstraZeneca, and this trial is developed to be a registration trial to get a drug approved for uveal melanoma. And in the lab, if we combine the selumetinib, give that concurrently with chemotherapy, it works better than if we give either drug alone. And I can go through the reasons for that, but that is the bottom line. And so that's what this study is going to be. It's going to be the MEK inhibitor with chemotherapy versus chemotherapy alone, with the possibility of getting the MEK inhibitor later. And this trial should be open up by January. The second trial is studying that commercially available MEK inhibitor called trametinib with an experimental drug called GSK795, which blocks AKT. And this is based on that cartoon that I showed you where if we block both pathways, things would be better. And this is a trial that we're leading in collaboration with the NCI, and we just opened this trial up this past week. And the third trial, which is open in Europe right now and will open up in the States shortly, combines the Novartis MEK inhibitor with their PKC inhibitor. I just want to kind of highlight this trial because I think this is one of our priority trials, which it's a similar design. Again, it's a randomized study like our first trial, but here we're taking patients who have metastatic uveal melanoma who have not received a prior systemic therapy. And they're randomized to either trametinib alone, which is the approved MEK inhibitor, versus the combination of the MEK plus AKT inhibitor. And if you're randomized to the MEK inhibitor alone and your cancer grows, you can cross over and get the combination. And again, this trial just opened at Memorial, but again, I'm committed to getting allowing access to these novel things to as many people as possible. I think that's good for everyone involved. And so this trial we're going to conduct through what's called the International Rare Cancer Initiative, which is an organization that consists of the National Cancer Institute here, a group called the EORTC in Europe, and then Cancer Research UK. And what we're going to do is we're actually going to open up this trial in 15 sites, not just in the US, but also in Europe and the UK. And so that's the plan. We should be able to finish accrual to this trial hopefully in less than 2 years and get the answer. Because again, we want to do this stuff as fast as possible. PKC. I think what I want to do is, let me just skip over here for the sake of time. And I just want to point out that, a lot of the advances I think we've made thus far in the field is based on our understanding of the biology of this disease. What are the key drivers? And, we talked a lot about GNAQ and GNA11. A lot of you guys are aware of BAP1, and we're still trying to figure out what the functional implications of that is and if we can develop a therapy for that. More recently, there was a mutation in something called SF3B1. And again, that's something, it's a recurring mutation. We find it in uveal melanoma. We're not quite sure what it does or how we can build therapies around it, but we're trying to work on that. Based on that work and others, what I've done here is this is a list of all of the currently accruing clinical trials for patients with uveal melanoma. I was going to go through this top to bottom, but maybe for the sake of time, I'll not do that. But this will be available, I think, on the website. So you guys should have access to this. Maybe I'll pause here. Do you guys have any questions about what I've talked about so far or about any of these trials in particular? Because, and one of the questions will be, what is the best trial for me? I don't know. If I knew, that's what we would be doing. I'm very biased towards MEK-based therapies. And so, the trametinib plus the AKT inhibitor I'm very excited about. The, Novartis combination I'm very excited about. The selumetinib trial I'll be very excited about. But I think many of these are very, very reasonable and promising. Question?
So if you have a tumor and you have had it, primary tumor radiated, and it doesn't take, would we come to you?
Yeah. So, I think, again, I know at Jefferson and at Memorial and at MD Anderson, a lot of the large centers, we all work as a team. So I work very, very closely with our ophthalmologists and radiation oncologists. And so we all know about all of the same cases. And I know Dr. Sato does the same thing here. And I think at all of the centers, for all the speakers, the places where we do this, we work as a team. And so I think if there's failure, if the cancer grows in the eye after radiation, that's still a local problem, so you probably deal primarily with your ophthalmologist. Okay, the time that you see me is usually to discuss are there treatments we can do after the radiation, or if it comes back, that's when you need to see someone like me. Let me see. I've listed here some of the adjuvant trials for uveal melanoma. I'm sure there are going to be a bunch of questions about that. Yeah. Yeah, the vorinostat trial, initially the idea of blocking something called histone deacetylase came from work by Bill Harbour, suggesting that tumors, particularly those with the BAP1 alterations, the BAP1 loss, would be sensitive to these, what we call epigenetic changes, and that HDAC inhibition, which is something that vorinostat does, would make sense. In the lab, this clearly has anti-tumor effects. Our trial, the vorinostat trial is ongoing. It's open at Memorial and just opened up in Vanderbilt. And we've got, I think, a dozen patients on or so. We have seen some stability, some shrinkage, but I think the patient numbers are too small to really make any conclusions yet. Yeah.
You mentioned that you
consider really clinical trials the standard of care for metastatic uveal melanoma. And in realizing how important trials are, obviously, to continue to make progress, but are you saying that you feel, in your opinion, that clinical trials still offer the best the longest term survival compared to, let's say, liver-directed therapies?
That's a good question. That's a good question. So I have a liver-directed therapy slide, but I'm not going to talk about that because that's Dr. Sato knows far more about that than I do. But your question is an incredible one, and we talk about it all the time. How do we best select the patients for a liver-directed therapy versus a systemic therapy? The bottom line is we don't know 100%. Well, we don't know, but we can make rational guidelines. So for instance, if you have liver-only disease, if the likelihood is that the disease is truly just localized in the liver, if it's relatively modest volume, then maybe liver-directed is the right thing. Whereas obviously, if you have disease outside the liver, and there's a lot of it, then a systemic treatment is the best. So on those two kind of extremes, I think the answer is clear. But in between, I don't know. And I think if you see 10 different doctors, you might get 10 different answers. But I think the bottom line is I think we all have our own opinion, but we don't have the data to answer that. The one trial that I'm actually very excited about is this trial being performed in Scandinavia, where I think this trial potentially will answer that question, where patients are going to be randomized to isolated hepatic perfusion versus whatever other therapy someone wants to give them. And so that can potentially answer the question, but we don't have the data for that now. I wish we knew. It's an important question. Yeah.
Well, I was just wondering, if you had to make a choice with the best information you had, and you could get into a clinical trial and hold off progression as long as possible, you could always go to a directed liver trial instead of the other way around, because if you have radiation, you might be precluded from entering the trial, right?
Yeah. Yeah.
I'm just wondering
how to go about doing things. I think I'm fortunate because I've got Jefferson very close by to New York, and so Dr. Sato and I just share patients all the time. We just kind of figure out. I think maybe it's better. So I have that luxury. For the individual patient who is not in the Northeast, it is a little bit harder, and I don't know. Again, if there's one spot of melanoma in the liver, I think liver-directed therapy makes a ton of sense. But as you get more and more disease, then the decision's going to get a little bit harder.
Rick, are any of the trials you're working on excluding patients who've had radiation therapy to the liver?
No.
That might answer your question.
Yeah, thank you. Good answer. Thank you.
Many of your trials exclude people who have had your point.
Yeah. And this will be, yes, so the question is, if patients have had prior treatment with, let's say, Yervoy or trametinib or chemotherapy, will you be excluded from some of these, these clinical trials? And the answer is yes, but it's going to be the minority of them. All right. Oh, yeah.
Another question about the genetic testing. Would you be excluded if you had not had genetic testing?
For the metastatic trials, no.
Metastatic? Okay.
Yeah, and for a lot of the trials, what we have, at least in the trials that I'm involved in, we are getting baseline genetic testing on almost everyone, and we're doing that by if it hasn't been done before, then we're getting new tissue or doing a new biopsy to figure it out. Because that's important to help us figure out, does the mutation predict a response for like one therapy? So that's very important for us to know.
Right. So if they hadn't had the genetic testing done for the ocular melanoma to begin with, and they got it in their liver,
we can do it off the liver.
Do it off the liver, and then you can make a concoction and kill it that way.
Yep, that's right.
What do you decide on your population for each trial? Like, what trial you want to put certain populations into? Is it up to you to decide what trial patients to go in?
Yeah, I think as we develop, as we try to develop the is we tried to find out which treatment is going to work best in which patients. We designed the trial to try to put on the patients who we think have the highest likelihood of it helping. And so we spent a lot of time trying to figure out, is it okay if a patient had another therapy, or is it not okay, based on kind of if we think it'll affect the response to therapy. And so this is a decision made by the investigators, if the drug companies are involved with the drug companies. And in the end, we end up with a clinical trial rule book, and that's just what we follow. Yeah, but a lot of thought goes into that. Maybe I'll kind of finish this. So in summary, I think, emerging insights into the biology of this disease, it's led to a generation of trials that are now testing really rational therapeutic strategies. I do think that MEK inhibition with selumetinib is a promising therapy for patients with this disease. And again, we did double the duration of disease control when compared to chemotherapy. It's really the first time we've been able to show this sort of effect with any systemic therapy. The next set of clinical trials are really building upon what the efficacy of what we've done so far. We want to build on our successes. The role of immunotherapy as well as liver-directed therapy is also important. That's being explored in a number of ongoing clinical trials. And I do strongly feel that patient participation in these trials, both in the adjuvant and metastatic setting, is really important. We can't do this without you. If our goal is really to find treatments that work, we have to work together. I need to thank a lot of investigators at Memorial. We have a big team that work on uveal melanoma, including our ophthalmologist. We have a big laboratory program that's important in us figuring out which drugs we think will work. This is our whole medical oncology group. We work with dedicated radiation oncologists, biostatistician, pathology, interventional radiology. And I also have to thank kind of all of my co-investigators at the other institutions who help us with these clinical trials, including Jefferson here, including Dr. Sato, and all the funding support, which we couldn't have done our stuff without. So I'll leave it there. Thank you.